And that's the most important thing. I'm there for you. I'm there for you. Mine.
Good morning, everybody. Before we start, ladies who's wearing pierced earrings, check and see if you're missing a pierced earring because it was found on the floor here. Anybody? Okay, I'll bring it up when I come back that way. All right, good morning. I am Darryl DePompio. I'm a member of the committee, and I am here to welcome you, and I'm going to present our next speaker. The title of our topic today is Protecting Our Own, Supporting ED Nurses Facing Workplace Violence. Our speaker is going to be Mario Viscardi. Before we get started, and I'm sure you've heard this before, I'm sorry, I'm being redundant, but I want to make sure you know you only have until April 18th to claim your CEs. So don't let it go past that point. You will get an email from ENA telling you how to claim them. So just stay on top of that. Before we go on, please make sure your phones are turned to off or silence. You can answer them, but go outside and take the call. And with that note, it's my pleasure to welcome Mario.
How's everybody this morning? Good? All right. All right, so my name's Mario Viscardi. I'm one of the directors of the Emergency Services, the Emergency Department at Claremont Medical Center, located in lovely Belleville, New Jersey. So today, I have no disclosures. I'm not getting paid by anybody to mention anything in here. There are some products in here. That's just what our healthcare system is using, but I'm not being funded or anything by them. Okay, so we're going to talk about. We're going to start with the trends, specifically in healthcare in general, and then I'm going to mention a lot of my data comes from Robert Wood Johnson, only because we have plenty of it to pull from, unfortunately. Okay. So I think everybody would agree that there's a problem in our ERs when it comes to workplace violence.
Houston, we have a problem.
So raise your hand if you have ever been personally involved in workplace violence, patient, visitor, worker on verbal, physical. Hands up, keep your hands up. That's a lot of hands. Okay, keep those hands up. Now, for those who don't have your hands up, do you know somebody who has been involved in workplace violence? Verbal, physical, worker on worker, any shape or form. Hands up high, hands up high. That's like 99% of the people. Okay, thank you. So it is a significant problem, it's pervasive, and it's ongoing. As much as we try to combat it, it's still happening. So some of the objectives, these are a little different than what's posted on the app, and I'm going to explain why. So we're going to define what workplace violence is in the context of healthcare. We're going to talk about why EDs are such a high-risk area. We're going to discuss the impact on healthcare workers, and I say healthcare workers because it's not just nurses that this impacts, but nurses are a significant portion of patient care and the healthcare system. It's not just the people, it's the system that gets impacted as well. And then talk a little about some prevention strategies, policies, best practices. Can everybody in the back hear me? Because I'm a walker talker. Good? Okay. All right, so we need to define the problem. Anybody throw this out? What is workplace violence? What do you think the definition of workplace violence is? Anybody? There's no wrong answer. Well, there is a wrong answer. No, it's not.
If I feel threatened.
Okay. Anybody else?
Physical harm?
Okay. All right, so OSHA defines it as any act or threat of physical violence, harassment, intimidation, or other threatening behavior that occurs at the work site. They're very generalized in it because it's OSHA, so it could be a construction site, it could be in a bank, literally any business or any organization. The World Health Organization defines it as incidents where staff are abused, threatened, or assaulted in circumstances related to their work, including commuting to and from work, involving an explicit or implicit challenge to their safety, well-being, or health. Okay, so it's pretty broad, and the World Health Organization talks about things that happen to you on your way to work, on your way home from work, because road rage is always going to be a thing. And I'm going to talk a little bit about something later on that I'll kind of circle back around to that. All right, so some of the trends in healthcare. 2020 is the last date that the Bureau of Labor actually has data that we can pull from. So it's 5 years old, but it is the most recent data. 73% of all non-fatal workplace injuries and illnesses due to violence are healthcare workers. That's in the United States. So think about how many people we're talking about, and it's still almost 3/4 of that number. Almost 69% of hospital patients felt very safe. Now, you might think I'm trying to be optimistic here. I'm going to drop the hammer now. In 2020, from 2023 to 2024, that's a 5.1% decrease. The number's going down. People say they feel very safe, but it's not as many people. Okay? 70% of Americans say hospitals need to improve physical security from 2023. Okay? Improve it, meaning they don't think it's adequate enough. If you ask your security director, he's going to say, yeah, it's fine. 85% of emergency physicians believe the rate of violence in EDs is getting worse over the past 5 years. That's ASAP. The American College of Physicians sent a survey out to all of their membership in 2022, and almost all of them believe it's getting worse, because that's what they say. So healthcare workers who experience violence are more likely to feel anxious, depressed, and burnout compared to those who did not. What do you think the percentage is who experience anxiety of nurses who experienced it? Throw a number out.
30.
30? Anybody else? 80?
85.
85%. Okay. 85%. How about depression? Hedging those bets, I love it. All right. Somebody likes to peek at my thing. Okay, 60% report depression.
Sorry.
All right, burnout. Let's see who the statisticians in here are.
95.
Ooh. That was, anybody else?
I think so.
81%. High numbers, high numbers, okay? And this data's from the Center for Disease Control. Okay. Little bit nugget. 39% of US adults say they are likely to avoid going to the hospital due to concerns of violence. So think of that number. These are people who don't want to come to the place where they need to go to get the help they need. Okay? So it directly impacts healthcare overall in the country. People aren't coming to get the help they need because they're afraid they're going to get hurt at the place where everyone, like Cheers, where everybody was. Okay. So, Disney World, the happiest place on earth. These are all recent articles about Disney World, where we would think, happiest place on earth. Fighting, gun violence, people running in the street, rude behavior. Okay, there's I don't know how many TikTok videos of people in the park arguing because they think someone cut them in line. You know, and the park security's throwing them out. So it's not just healthcare. Where's the other place you think you see a lot of little workplace violence? Planes, airports. I actually enjoy watching those. Those are the ones I really like. But it's a pervasive problem. There's a Senate bill. It's Senate Bill S13, 1939. It's part of the FAA Reauthorization Act. And it basically, they're looking at training all flight crews in the United States, thinking of how many flights there are, to provide de-escalation training to them. They don't actually get it right now. Okay? I mean, they train them how to, basically what the rules are to kick somebody off a plane, but they don't really teach them how to de-escalate a situation and try and resolve it. And everyone in here has seen a video about, throwing people off because the airline made a mistake. They doubled what we see. Okay, so these are just a little sampling. Here's another little nugget. In 2023, there were 2,075 unruly passenger reports reported to the FAA. In 2024, it was 2,102. So it increased 1%. That's just 1 year of data that we pulled. So their issues are going up too, which is why they're talking about doing de-escalation training with all of their flight crews. Okay. Close to home. This is close to home, kind of in terms of New Jersey, as well as these are all, what I'm going to talk about are things that happen in hospitals. This is Newark Beth Israel Medical Center, which is up in Newark, New Jersey, part of the RWJ system. 2 nurses and a medical resident were slashed by a visitor in the pediatric intensive care unit with a box cutter type knife. There was a disagreement. It happened shortly before 7 a.m. Hospital went on lockdown. They basically diverted all kids away from the hospital. As of this presentation, the 2 nurses involved have not gone back to work yet. And this is from 2023, December of 2023. Okay. This is really close to home for us. We had an issue with one of the directors was surrounded by staff and a non-employee representative about another employee, another nurse who had been disciplined. They surrounded, and the director did not feel safe because of, and then there was discipline involved with all the people involved, but you know, these types of incidents still happen. Palm West Hospital. I think everybody read about this recently. Okay. The patient was brought to the hospital under a Baker Act. In Florida, that is a law that allows family members to report, a relative who may need mental health services and that they're not able to make decisions for themselves. The police brought them in, and then this patient violently attacked the nurse, severe head trauma, facial injuries, and the last that I could find, she most likely will be blind for the rest of her life because of the facial fractures and organ injuries she had. This is actually in Philadelphia. I don't know, there's some Philly nurses that may 3 nurses at a trauma center. It was Penn, I believe. Drive up, gunshot wound in the car, happens all the time. And the nurses rushed out to get the person out of the car. Police, and most places will notify the police immediately when a gunshot victim shows up in a car. And police responded pretty quickly. The person who was driving, still sitting in the driver's seat, saw the police coming and took off and injured the nurses because they were still trying to take the person out of the car. Okay? So just, again, in the course of doing our job, all of these, and it was outside, just trying to help somebody out of the car, and basically 3 nurses get hit. But who would you think I got hit by a car at work? I work in a building. This is the other one from UPMC in York, PA. This was the nurse who was held hostage, had her hands zip tied behind her back. It was the husband of a terminally ill patient in the ICU who had passed, felt they didn't do enough, and he wounded several people, fired several shots with a handgun. The nurse recounted later. She said, this is a quote from her, there was a moment where she had the gun to her head and he pulled, or I'm sorry, her son, and he pulled the trigger 3 times. I guess he was out of ammo or whatever. That's something that really stuck with her. She thought she was going to die. That's from her son. That's basically what she told him. And then, they spoke with her briefly, and every time she closes her eyes, that's the image she sees replaying in her head. So, that's the long-term effects. This happened 2 days ago. Literally, I've had to update this slide every day. Troy Hospital, 2 workers in the parking garage had a disagreement shortly before 7 a.m. One guy shot the other guy a couple times and then took off. 2 workers. This is worker-on-worker violence here with a gun in the parking garage. They apprehended the suspect because the guy who was shot knew who he was. They knew he was an employee. They had his picture. I mean, it didn't take long. But that's kind of the closer to home stuff. So what's the prevalence when it comes to workplace violence? I'm going to say this, and I'm going to say it loudly. It is not, I repeat, none of this is not part of your job. Nobody should ever expect it as part of your job. I don't care if it's nurses, techs, doctors, I don't care who it is. You're here to help people, and when you go to the hospital, that's kind of the implied understanding. You came to the hospital and we're going to help you. So for people to lash out and create violence against the people trying to help you, still boggles my mind. I just have a hard time wrapping my head around that basic concept of reality. And as a nurse leader, and I tell my staff this all the time, it's not okay. If something happens and if I'm not there, there's another leader there, you need to let us know in real time, okay? Because A, I want to make sure that you're okay. B, I want to make sure that the situation has been, resolved, that it's not ongoing. And 3, I want to make sure, do I need to have somebody walked out of the building? Do I need to call the police? Do I, support you if you want to file charges? I want to be able to support my staff, and I let them know that I am here for them in those instances. And I'm Italian, so you can know how that goes. So I'm very protective of my staff. But it's also important that when you go back to your facilities, make sure that you have that kind of leadership. It's important. It's an important part of this whole discussion, that the leaders need to be involved and that you feel comfortable that they have your back, okay? Because we can't solve this, we can't fix it if your leaders aren't invested in making sure that you're safe or putting things in place to make sure that you're safe. Okay. Who here has ever experienced, now I know I saw a lot of hands that have been involved in workplace violence, verbal, whatever the case is, but didn't report it. Which is a safe place, so you can, your bosses probably aren't here. Hands up high, I don't want the half hands, I want to see hands, I want everybody to see it. Okay? Why?
The patient had dementia, so I was on the dementia ward at the time in my career, and I was intervening him grabbing another patient, and when I did that, he smacked me in the face, so I kind of like got him away from the other patient, but not that it was right, but he wasn't all in the head to know, you know what I mean? Like, he was just swinging, so I didn't feel the need to report it because he had dementia.
So we're going to talk a little bit about what you just mentioned. So I'm going to say this, no matter what the situation is, you should report it. This is why. To make change, process change, culture change, anything, we need to track, we need to trend what's happening. Is it getting better? Is it getting worse? Is it staying the same? If it's getting better, then we look at, well, what are we doing right now? Okay, let's keep doing that, but what else can we do to make it even better? If it's getting worse, what we're doing obviously isn't working. We need to make some changes, okay? And in nursing, what do? We try something, it doesn't work, what do? We go back to the beginning, we change it, try again. The same thing with workplace violence, but it's important that people report these things, okay? There is, no one should ever feel like, I can't report it, they're gonna look down on me, fear of retaliation, that should never happen, okay? Workplaces have standardized reporting systems, they have policies and procedures about when to report, how to report, but it's important to report. At the end of the day, it falls on you as the nurse to report it. Nobody can force you to, but at the end of the day, it's important because we rely on that information. So if I want to implement something, and maybe there's a there's a cost involved with that. I need to show the data to support what I'm asking for. If I don't have the data and I ask for it and they tell me no, now, you know, I have to go back to my staff and say, well, I wanted to do this, but I couldn't. And I don't want the staff to feel like it's their fault, but it's important. That's my alarm to do my 11 o'clock huddle with my staff. Just so you know, I forgot to turn it off. See, I'm always at work. And my boss is here, so I'm like, that's. Okay. All right, so kind of what you spoke to, who should we worry about when it comes to workplace violence? All right, so when we talk about substance abuse, what condition, disorders do you think falls under the substance abuse? Alcohol, what else? I heard from here.
Drug
Drug use, okay. Okay, so kind of the typical ones, like that's the easy one. So why do we think substance abuse causes people to have outbursts or, you know, or be involved in workplace violence incidents? What about it? What does substance abuse cause?
Altered concepts.
There. So it disrupts brain activity. You know, it impacts people's impulse control, their ability to regulate their emotions, and judgment, because someone who's high on PCP doesn't have any. They're just monsters with unbelievable strength. So I love saying this one. Would anybody be surprised if I said caffeine and tobacco are actually part of substance abuse in terms of what we're talking about? Who here, more hand raising, who here is not fun in the morning without their coffee? Okay, who here smokes? Don't worry, no judgment. Who here smokes? And if you don't get your cigarette, you'll be able to crank it, right? Cognitive disorders. What do you think, what cognitive disorders do you think? Alzheimer's? Throw the big ones out. Dementia, you mentioned dementia earlier. Autism. Yes, good. Any others? TBIs. Okay. Huntington's disease. I know no one thought of that was coming out of left field. It's a genetic disorder, but it causes cognitive issues. There are, I believe the number I found, there are 5 different types of dementia. ADHD. Probably everybody else in here too, because that's why we went into healthcare. You know, our 30 or 45 minutes of focus, and then I need a break. I need to go smoke, I need a cup of coffee, and then come back and do it all over again. But there's some actual medical diseases that will cause cognitive issues that lead to outbursts. Dementia is a big one. And then behavioral. Throw out some behavioral. Schizophrenia. Bipolar. Autism again is in there. Okay. Autism is, that's a 3-hour presentation all by itself. Actually, I could probably spend the next year talking individually about all of these just on that, because they're so important, but we have to rope all of it into one big category. And as ED nurses, we have to handle everything. Doesn't matter what it is, ED nurses do everything. We're the jack of all trades, master of none. Okay? You know, ICU they're great at the really sick patients, but they focus on those type of patients. You know, the behavioral, they worry about the behavioral, they don't care about medical. Actually, they won't even take them if they're not medically cleared. Inside joke. Eating disorders, PTSD. Okay. Especially nowadays, you have, you know, the drawdowns and a lot of our veterans coming back from overseas, a lot of PTSD. A lot of talk in the news about veteran mental health. Mental health in general just is a big problem in this country, but you know, we're talking, you know, specifically, that's a big population as well. Okay. So what are the challenges for everybody in the ED? So we talk about patient factors, perception of threat. Okay, not all patients who come in are happy about being brought in. Okay, they may feel like they're being forced to go somewhere they don't want to go. Now they feel threatened. That's their perception that there's a threat against them. No matter what we say to them, we're here to help you. You talk calmly. It doesn't matter. Their perception of threat is elevated. Negative interactions with. I love this one. Who here has had law enforcement bring that patient in with EMS and trying to get him on the stretcher and and listen, I love law enforcement. A significant number of my friends are in law enforcement, even family. But they go from 0 to hot, get on that, or I'm going to do this to you, whatever the case is. And now what happens? They leave. And now they just lit a firecracker under their keister, and it's about to go off after they leave. Okay? That's something that you need to think about, okay, early on, especially if you see that happening. You need to try and de-escalate that while they're still here, because I've actually said, whoa, where are you going? Stay here. I'm like, you just got him all riled up. You're not going to stay and help us in case he goes off. That's me though. I don't. You're going to stay. You caused this. You're going to stay and help us fix it. Okay. System factors. So these are things, not specifically the place, but it's just the environment. Census. Okay. High census. Even with the best staffing in the world, if it's busy and you can't get to these people, to see them in what they perceive is an adequate amount of time, it increases their anxiety levels, and then they start getting mad, or the family members that are with them might get mad. Inadequate staffing, kind of as I mentioned, is everybody has this problem. It's never going away, ever. It's just part of the built-in issue that we always have to deal with. And then, I swear to God, poorly designed ED layout. I have to preface this. So every time my boss talks to me, she goes, anything you need, I say no ER. For the last year and a half. But that's an important part of it, because where you put people, do they feel like nobody sees them? They're kind of stuck in a corner. That plays into all this. Oh, nobody came to see me. You stuck me in the corner, like you don't care about me. Performance. So, staff knowledge. How much education has your staff in your particular facilities gotten on patients that may have some behavioral health issues? Some places don't have behavioral health services at their hospital, but they're still coming to you because we have to take care of them. And then when we talk about competing priorities, you have multiple, as an individual nurse, we have multiple patients, okay? And ED nurses are fantastic at on the fly reprioritizing, because if you can't do that, you're going to get run over by the patient train. So it's constantly reprioritizing based on what the next patient came in with. This one's really sick, everyone else has got to wait a few minutes. But now you have a patient who's like, well, why am I not being seen right away? Well, the person next, in the room over here is literally dying. Like, actually, their heart just stopped. But they don't care. They don't want to hear that. To them, it's an excuse from us. Team factors. So, lack of coordination. if you have a great team, your leadership, your charge nurses, resource nurses, whatever you call them, but everybody's working well together, that reduces the ability of patients to not get seen quickly. Like if you know that I'm not gonna be able to get here and you let the charge nurse know and they'll grab a float nurse to go over and see that person so they don't have to wait long. That's part of like good coordination. When you don't have that, you know, then the nurse feels like they're on their own and they're running all over the place trying to keep up with the volume. Lack of standard process. That's a big deal, especially if you start running into the same issue over and over, i.e. tracking and trending. That's why this becomes important. Because if we see the same thing happening over and over and what the outcome is, we know as leaders, we need to put a process in place so that it doesn't continue to happen, or how are we going to solve it, okay? And then poor security measures. Everybody's going to have a different thought process on this, and there's never a right answer. It depends on your facility, it depends on how much security you have, it depends on, you know, the population you serve. Right? Those are all big factors in this, but it's important to make sure that you're working with your security, because later on you'll see why security plays a big part of workplace violence. And then behavioral factors. If you, pretty much 99% of the people raise their hand, either you have or you know somebody who's been involved in workplace violence. That doesn't go away, okay? It never does. We're just really good at suppressing it, because we need to go back to work and take care of all the other patients we still have. But that leads into, now there's judgment. You know, now, and we've all thought it, I'm gonna say it, what I believe most people have said. Oh, this one's coming in with whatever this is, you know, they're acting like, you know, they're crazy, this is ridiculous. You know, they just want a sandwich, they just want a place to, they're not really sick, they're judging. And that goes into bias too. Now they may say, I can't deal with this anymore. I can't deal with these patients. It's ridiculous. I have other patients I need to treat. And then their personal discomfort. They may say, I can't deal with behavioral patients anymore. It's been like nonstop. I don't want to do it. We'll get a little bit into statistics. I know I've been like the downer. Okay. This is data from Robert Wood Johnson. We are a 13 hospital system as of today. This is information from January 1st, 2018 to January 1st, 2025. There have been 16,087 incidents of workplace violence across all of our hospitals during that time. You can see clearly the escalation. It just keeps going up. Okay. I want to point out 2025. You see when the data was run on January 8th. So from January 1st to January 8th of 2025, there have been 60 incidents of workplace violence in our system. That's the average incidence per day in our system. Okay? And it's not like we're not trying to reduce this. It's not like, I don't want people to think, wow, you guys are just like the Wild West. It's not. We have a lot of things in place, and I'll talk about them. But it's still a problem. Even when you put a lot of effort into it, okay, it's still a problem. This is only 10.5 months, because where I got the data from, they had run this, and they were being very nice and giving me all this information, so I didn't want to like ask them to keep redoing things. So this is from January 1st to November 13th of 2024. Almost 3,000 cases when you subtract out the other months. So this is a breakdown of the types of workplace violence: 58% verbal, 38% physical, 3% sexual, and 1% written, meaning somebody sent a letter or an email that somebody construed as, you know, workplace violence. And then nobody left anything blank. That would be silly if you left it blank. How do we know what the problem is? But within those, you can see on the left there what the actual issues were: kicking, punching, biting, verbal threats, death threats, knives, guns, strangulation. Okay. I think 73 people removed from the property is underreported, but that's the data they presented. And then on the bottom you can see what the actual injuries were. Okay. And I'm thinking, I can hear the whispering. Some people are probably saying, "Oh yeah, that's, oh yeah, I got scratched," or "This one punched me." So, it's across the board, the types of injuries, from severe to what we would probably like, "Oh, I just got a little scratch," not so severe. So this is the injuries by the other group. When I say the other group, it's outside of nursing and outside of security, because who do we call when there's an issue? Security. So that's why I said later on, you'll see how important we are together. So all others is 110 other job titles. We kind of broke it out and added these because these are also people that work closely with nursing, whether it's on the floor, in the ED, anywhere. Places, facilities that have behavioral health. They have their mental health associates. So that's why we kind of added all these other ones in here, okay? So out of the 4 job titles out of that 110, that's how many were involved in issues out of that. So 52% of all workplace violence injuries are security and nursing, okay? And then you add in the other, these, out of that other, it's 72% of the staffing, okay? So when you add these into these numbers, 72% of the workforce. Bless you. Okay. So how does that impact healthcare workers? I use this graphic because I think it's a pretty accurate progression of the things that we feel or have to deal with long term. So the initial incident kind of would start here, and then whatever injuries we suffer, if there are any. Some injuries we don't see, it's just, and we move on and go back to work. It's the couple of days later, it's the couple of weeks later. And then you start getting a little chronic stress. You don't realize it. You might not realize it, but it's there. May not impact you at home. It might start to. You might have a family member that says to you, "Is everything okay?" Because you're different. And you're like, "Oh, no, I'm fine." Because ED nurses are always fine. We're always fine. We're fine. But then it keeps going. You're starting to feel a little burnt out. You're like, "Oh my God, I gotta go to work again." Even if you love your job, you love where you work. You're like, "I don't want to go to work. Oh my God, I need a mental health day." That's why PTO came about, by the way. Everybody knows that, right? It just made it okay for us to take our mental health days. That's why PTO came about. But then it keeps going, and then it turns into PTSD. Okay? And I think a lot of people in here have encountered patients with PTSD and some of the symptoms. Loud noises set them off. They watch a TV show and it reminds them of whatever might be the trigger of this. And then now they're not getting, they may not be getting help. So this is just festering, okay? And it keeps festering, and it gets worse and worse, because if we don't control sepsis, what happens? It gets worse. So that's why I like using this graphic, okay? It kind of shows the progression. And I don't know if anybody in here knows anybody that went through this and kind of watched the progression of this, and hopefully it's not giving you PTSD that I'm reminding you of it, but it's important to talk about it, because we need to deal with it way down here, not before it gets up there. All right, so how does it affect patient care? Well, the nurse who is taking care of our patients, it's affecting them. But now Now this is where the down the line issues start to snowball. We're at the top of the mountain, we're gonna throw a little snowball, and we're gonna see what it looks like at the bottom of the hill. Decreased morale, okay? I'm not sure I wanna be in ER nursing. I don't even know if I wanna be in nursing anymore. Because since COVID, we've dealt with COVID doing that to us. And now we're adding workplace violence onto that issue, which is why we don't have as many nurses as we did, because a lot of them retired, and they're like, I'm not doing that again, not even risking it. Impaired decision making, because now, you know, you've got this incident that may have happened to you on your mind, and you're second guessing yourself, or you're taking a lot more time to make decisions. Compassion fatigue. Anybody in here heard that term before? Compassion fatigue? It's an unfortunate side effect of a lot of things, but it's a real thing. And we need to make sure that we are taking care of ourselves so that that doesn't happen. If you lose your compassion, you gotta get another career, because it's literally the basis of what we do. We care about our patients, we wanna take care of them. If we have compassion fatigue and we're finding that it's hard to be compassionate, that's a big problem. And then delays in care, kind of, you take all of those other things, and now the patients aren't getting taken care of in a timely manner, because the nurses second guessing themselves, or taking a lot longer to make a decision or do things, or they're not as compassionate to their patients. Pick up on that stuff too. When you're not as compassionate, like, you know, patients understand that. Now, how does it affect the organization? I talked about this earlier. Increased absenteeism, because now people are going to start calling out. I don't want to go to work. I can't see another whatever. I can't worry about being beat up again at work. We talk about workers' compensation claims for people who are injured at work because of these incidents. Legal costs. When it comes to, and I'll talk a little bit about this, at Robert Wood Johnson, if one of our employees is involved in a workplace violence incident and the employee chooses to press charges, we support them. What also takes place is our security passes up the line, and our corporate legal department will assign an attorney to our employee to assist them in the whole process. Following up with them when eventually the case goes to court, all of that is maintained. And it's so the employee doesn't feel like, okay, you did this, now you're on your own. We support them through the whole process. And unfortunately, everybody knows, you know, the judicial system is not the swiftest. If they had to keep our metrics, they would be. But they don't. So that's something that we do at Robert Wood Johnson. And I have some employees who have filed police reports, and I check in with them frequently. Have you heard anything? How's everything going? Are you okay? I would make sure, because if you're going down that line, then it's a significant issue if you're willing to file police reports on an incident. And he, you know, the employee gets back and he's like, yeah, I haven't heard anything. I got to give him a call. He has the lawyer's cell phone, so he has direct contact with them. So I always check him. And then productivity, because again, as we talked about before, delays in care, impaired decision making. You're slowing down, you're not seeing as many patients, we're not moving the patients, either discharging them or getting them admitted in a timely manner. That affects productivity, and a hospital runs on productivity. We need to move in, up, or out. That's the flow. With workers' compensation claims, for 2024, Robert Wood Johnson, as a system, paid out $1.5 million in workers' compensation claims due to workplace violence. Okay, significant cost. All right, so some strategies, interventions, and these are things that we're doing at Robert Wood Johnson. Hopefully it's a similar, you hear some of the similar things that your facilities are doing. Environmental and security, cameras, security personnel. Our facility invested in high definition cameras. So we get, you know, good quality images so we can really see what's happening in real time, and they're strategically placed throughout a facility, which they should be. Hopefully your facility is the same. You should be constantly reviewing layout changes to when you do construction and you're changing the layout of the ER. There should be a constant review of, or changing the layout. Do we need to alter our security procedures in the ED? How the flow of patients, is there any areas where there might be a concern? Door access is a big one. You want to make sure that, like, the important areas are controlled with door access. Someone shouldn't just be able to walk in and out of the ER unfettered. We want to control that access. For us, something that we've done recently is we now ask security when we're holding a lot of behavioral patients on watches, one-to-ones, Q15s, whatever. I call the director of security and I say, can you please post the security officer in the area? He's going to sit there while we have all these additional patients, and he gets back to me and says, okay, I got a guy there now. Are you going to need somebody, you know, after 11 p.m.? Do I need to call somebody else in? That's the collaboration that we have, and it makes me more comfortable that my staff has that extra layer of security, and I know it makes my staff feel comfortable because I talk to them about it, and they feel more comfortable that that extra layer of security is there. It doesn't sound like a big deal, it's a simple phone call, but it has more wide-reaching effects in a positive way.
Mario, just a question.
Sure.
Whose budget does that come out of? Does it come out of yours or out of security? That
So-
would be the first question our security director would be.
So-
How am I gonna pay for it?
I never asked that question?
No, it doesn't come out of the ED. We do speak to security because we've been able to, talk with security, and they allocate security already in the ED, so we rotate them in different areas.
Gotcha.
I'm going to talk a little bit more about the security part and money. Staff training and education. That's like a huge part of this, okay? Trying de-escalation, and that's a little further along, but that's the word everybody has heard, de-escalation. Techniques, crisis intervention, conflict resolution, recognizing the signs early, not late, okay? You recognize them early, preferably before the law enforcement, the police officer lights the firecracker under them. The success of de-escalating goes up, okay? But when we catch it too late, it's a lot more difficult. And a lot of times, even the best strategies done perfectly won't work. Organizational policies, clear anti-violence policies, zero tolerance, standardized policies, procedures, are all, including like post-incident reviews. Like after something happened, it's important to talk about what happened, what led up to this, and it's not meant to be, well, you did this wrong. It's what happened. I want to make sure that it doesn't happen again. Do we need to fix something, or is this just, you know, we did everything we could, and things still happen, even when we do everything the right way. That's the other thing I want everyone to take away from this. Even when you do everything you're supposed to, you follow the policies, you follow the procedures, the training has been burned into your brain, and you did everything they taught you, things will still happen. We cannot control the other side of the equation, which is the patient or the family. We cannot control their emotions or their reactions. Teamwork and communication, okay? This talks about, like I've been talking about, it's multidisciplinary approach, security, leadership, education, making sure that everyone's on the same page, we're teaching the same thing, everybody's been educated, and that maybe we do drills. Make sure we do some multidisciplinary drills. With all the stuff that I talked about early on, we have plenty of scenarios to pull from recently to make, you know, especially in these instances with guns being brought in, it's a perfect situation to try. Well, this just happened elsewhere. It's a recent event. How are we going to handle that? Can we handle it? Okay. And then stress management. EAP, I don't know if anyone has the same thing or something similar. You know, it's a hotline, it's free, it's a benefit that everyone in our system gets for free, that they can call and speak to somebody if they're having issues related to an incident that happened to them. Peer support, a debriefing process. A lot of times talking things out really help. You know, it's not, you're not burying it down and we're just, you know, it's gonna boil over at some point because we're not getting it out. All right, so real quick, we created a corporate security department within RWJ in 2022. And what they're doing is, I believe, they have a 5-year plan, and I think it's $50 million they're investing across the system in additional security officers, physical improvements for security, perimeter access, things like that. Panic devices, purchasing, spending money for individual panic devices for staff members. So, and I think the goal is to issue one to every employee so that when they hit it, it's registered to them, they know exactly who's pushing the panic button. All right, so de-escalation. Everybody I'm assuming in here has had to take this training at some point, at some place you've worked. Okay, so the early recognition, that's what we talked about. The agitation, pacing. I'm pacing, I swear to God, I don't need to be de-escalated. Raised voice, just increasing the tone of their voice. That's an early sign, you need to pick up on that, okay? Especially if they were talking calmer earlier, and now all of a sudden their voice is going up. All right, you, as the caregiver, want to be calm, respectful, and empathetic. You don't want to match their energy. At the end of the day, if you match someone's angry energy with some more angry energy, we all know where this is going, okay? It does not help. It actually will speed the process up. Non-threatening body language, speaking slowly, clearly, softly. No direct, intense eye, because that's a threatening to somebody who's upset. Like if you stare at them, they think that you're ready to, you know, it's an initiation of violence to them. Like, oh, he's going to come at me now. Active listening, just listen. Let them say what they need to say. Let them get it out. Don't interrupt them. Because then they just get angry, like you cut them off. The environment. See if you can move them someplace that's a little quieter, a little less, you know, surface of the sun bright, like all of our ERs are. It's like staring at the sun. Exits. Make sure you are not between, or the patient's not between you and the exit. Always keep your back to the exit, okay? That's a gimme, all right? And then keeping a safe distance. Don't be up close to them, because if you are, then they can put their hands on you very quickly, all right? Should at least arm's length and a little bit more. And if they they take a step towards you, you take a step back. If they take 2 steps, you take 2 steps, all right? To keep that space. And then crisis intervention. Let them feel like they're in control. If they don't feel like they're in control, this goes south. There's no talking that any other way. If they feel out of control, they will it'll become violent until they can gain control, and especially if that's with making threats or throwing things. Acknowledge that they're frustrated, because if you do that, they'll understand you're on the same page as them. That they now know, okay, they know I'm mad. Because if they don't think you know what's going on, they're going to keep getting mad, or they're going to escalate this, right? And don't threaten anything. That just ends the conversation. They stop listening to anything you say. They just said they're gonna take me, and 4 guys are gonna throw me on the bed, and I stop listening after 4 guys are gonna throw me on the bed. Doesn't matter if you said, and I'm gonna get you a turkey sandwich. Doesn't matter. Okay. This is what RWJ uses. It's called the Evolved Weapon Detection System. It uses AI. Basically, it's this system here. You walk through it, and it shows up on an iPad, and it gives a location on the person's body, and it uses AI to determine what the object may be. Right? And it's rolled out at all of our walk-in entrances in RWJ. the other facilities, so all 13 of our hospitals have this rolled out. This is just some information on it. 2.1 million individuals have walked through, 3,000 knives, 861 guns, 8,700 other weapons prohibited items, screwdrivers, machetes. I don't know why, but apparently people think bringing a machete to the hospital's okay. Are brought in. Okay, I'm gonna skip through this only because I only have a few more minutes, but the ENA did put a video out about workplace violence 3 years ago. Okay, you can go on YouTube and Google it. I highly suggest it's 7 minutes long, but I suggest you watch it because the ENA is well aware of this problem and they're working hard to try and combat it. New Jersey has a law separate from all the other stuff. It's called the Healthcare Heroes Violence Prevention Act. It was signed into law May 2023. This is different than the Title II-C, which covers assault. This one is specifically, and it covers only licensed professionals, RNs, LPNs, RRTs in its current form. It does not cover patient care techs, mental health workers, only licensed professionals. If they make, deliver, or send a threat, it's the verbal threat. They can be found guilty of a disorderly person's offense, separate from anything else they do, with punishable by 6 months imprisonment or a fine of up to $1,000, plus they have to attend an anger management course for 12 months and community service on top of whatever else, what other charges that they may get. The SAVE Act, this is on the federal level. 2022 was introduced, it hasn't been signed yet because the federal government is so efficient. Basically, it covers, outside of any state laws, it covers anybody, and the A part covers just general assault against somebody. Imprisonment and fine. Imprisonment 10 years or both. It doesn't state what the fine is. And then whoever, and if they use a deadly or serious weapon, it goes up to 20 years in prison. Okay? So they're pushing hard. The ENA, I believe, has been a big proponent of this and has been trying hard to get it pushed through. I have a hard time understanding why it's not already a law. And when everybody says, oh yeah, we understand, we support you, then sign the bill. It's that simple. It's great, we don't need another pizza party. I need you to sign the bill. Okay. So, a couple minutes. So I just want to ask, based on what I talked about, is anybody in their facilities doing anything a little differently than what I talked about?
So, I don't know if anyone else here is using this, but we're in the process of, I'm a nurse manager. Probably one of the biggest nurse within our enterprise, the National Crisis Center, for adults and pediatrics. And we're currently right now implementing a violence risk assessment tool with a violent flag policy. And I was wondering, protocol for electronic and mental record. And I was wondering if you or anyone had used this, a violent flag policy, and like door hangers, if anyone's doing that, because I'm more interested in, having those as well, because I have a violent flag on each right now. But I have students walking through and, and just being unaware of who's in the surroundings can really be kind of worrisome for a lot of people.
So,
we have that. It helps. You can actually, your patient can be fine, and you can, if something happens, you can problem, you can go into the chart, read it across it, and all of a sudden the flag will change, whether the flag, and security actually will call silvers, down. And but it's really nurse driven, so the nurses have to use this process. But it's part of our triage process as well, so it can be.
So we use a system that's called FastPass. So at our walk-in portion of the waiting room, as well as the front entrance of the hospital, everyone that comes in that is not a patient, they have to provide ID. It's scanned into the system. A photograph is taken. It is actually kept in the system. They have to give the name of a patient who is registered in our system to gain access to the hospital. And then once they do that, it's saved in the system. So if, and we instituted recently, we now take color highlighters, we highlight the date with a color, and it's random. We change it every day. So if somebody comes in on a pink day and the next day is blue, and they come in with the pink one, we stop them and we make them go back out, because there may now be a visitor restriction that has been entered on the chart. They may be the person who's not allowed. And our security uses that to prevent access. If the person's not supposed to be in there, they'll stop them. Fine.
You do that in the ED?
It's the whole hospital. Even for inpatients, it's called fast pass.
We're also part of WJ and Jersey City. I know we have that for inpatient visitors, but.
Yeah, we use it at the waiting room, the walk-in waiting room portion.
Okay.
We use it in the ED at Trinitas. In fact, everybody that comes in and applies for a job, I make them go through the weapons detection. I make them get a fast pass to show them that that's how serious we are about safety. So the patients are registered, we know who they are. And there's a alert system right for that too, where you can flag a patient as being potentially violent. I forget what name it has, but yeah.
Yeah, where we at, they have dogs.
I would love that.
I would love that.
It started out at Geisinger.
I would love to be like Germany.
UMPC.
There's no issues in Germany because everyone's got an Uzi walking through.
Only thing is everyone wants to pet them.
It's, I mean, there's a lot of things we can do, and that's why I said, like, you know, if I said I want armed guards, I need data to show the need for them to say, okay, you know what, yeah, this has been going, we did all these things, it's still not working. Yes.
If they go to the metal detector and then they get a full body scan, our fire rescues, even when they're coding for the shot,
Wow.
our guys come in and as they're stripping them, they're wanding. They're right next
Everybody.
to us, wanding, you don't know who you are. If you leave to go get high, or do whatever you want to do, they have to do the whole thing over again and get banned. Everybody has to go be banned, so they take it off as well. So, and even with that, like, we just had it going, in the decon room, that guy, like, went in the waiting room, we were like, oh, that's because of decon, he left his gun, like, on the sink, to wash up, and then, but we're trying, it's just amazing.
Every policy is the result of something happening. And hopefully once it happens and we do the policy, it doesn't happen again. But I'm out of time, so thank you everybody, I appreciate it.
Do you want me to end your recording?
Yeah.